Great. Welcome, everyone. This is the Women's Healthcare Forum this evening on Peri-menopause, presented by Dr. Thusitha Cotter, and then the topic of menopause by myself. I'm Dr. Mary Beerworth, also Rutland Women's Healthcare. Dr. Cotter joined us this summer, and she is a very experienced, wonderful OBGYN who we're very happy to have join our practice. And she's also a member of the North American Menopause Society, so she's very fluent with the subject matter this evening. So,
all right. Thank you very much.
Thank you.
Excellent. Well, thank you everyone for coming in this evening, although it's nasty outside and raining. So I have to say, this is a very exciting topic for me, and I get very excited when I get an opportunity to talk about it. So if I start going off on tangents or speaking too quickly, then just let me know. But as Dr. Beerworth said, I am part of the North American Menopause Society, and I'll talk a little bit about the society at the end of the lecture because it's very, very open to the public, and anyone can log in and essentially look at pretty much everything that the providers can look at as well, but it's completely open to the public. So I'm going to deal with perimenopause, which is that stage before menopause, and then Dr. Beerworth's going to talk about menopause. So menopause, so what is it? So it's the permanent end of menstruation, and it is a turning point. It's not a disease. Many people feel like it is because it can have such a big impact on their lives. And a lot of changes such as hot flashes, night sweats, changes in libido, vaginal dryness, discomfort with intercourse, all of those things can really start to change a woman's outlook on her life. And although all those changes happen, it can also be quite a rewarding phase. And as clinicians, we can actually see it as an opportunity when we can actually start to talk about prevention. So prevention of osteoporosis, trying to improve cardiovascular health, improving things like sexual dysfunction. So it can actually be a really good opportunity. This is a picture of the menstrual cycle, and some of you might have seen it before. The really important parts of it are the top row, which shows what your ovaries do during the menstrual cycle. The middle section shows what your hormones do during the menstrual cycle. And the bottom section is a cartoon of what's going on inside the uterus. And that bottom part is showing the lining of the endometrium as it changes during the menstrual cycle. And towards the end of that picture is when the cycle sheds, and then you have your menstrual bleeding. Now, before menopause comes perimenopause. So natural menopause happens very gradually. Your ovaries don't just abruptly shut down one day. It's a very slow transition, and that transition is what we call perimenopause. Now, menopause is that day that marks 12 months in a row since a woman stopped having her menstrual period. So menopause, we actually diagnose retrospectively because we need those 12 months with no period, and then we can look back and say, this is the day of your final menstrual period. Now, although a woman's childbearing years are starting to wind down during that perimenopausal stage, women are still ovulating, and that can be very important because even though your periods are unpredictable and you could have them at different times, your ovaries are actually still releasing follicles and you're still ovulating. So it becomes important to think about things like contraception and making sure that you don't want to get pregnant if that's not what you're planning. This is an interesting picture just showing a lot of the hormonal changes that are happening during the perimenopausal period, and this is showing women who are younger as the blue figure, so 20 to 34-year-olds, and then older women in the 35 to 46-year-old range as the red numbers. And interestingly, they actually pushed this study on up to age 52, and what it shows is that these women are all ovulating. So even though their hormones are doing very different things, they're all having ovulatory cycles, even though they might not be having a menstrual cycle every month. And that's important because that means you can still get pregnant. One interesting part, if you look at the upper right-hand corner where it shows the FSH, now I probably wish I had my pointer. So that FSH level, sometimes people will check on it, but it changes, it fluctuates quite a lot. And what they showed was as you look more towards age 65 and 75, that FSH level keeps going down lower and lower. And you can even have numbers that are in the premenopausal range. So FSH doesn't seem to be a very useful marker for telling us when you go through menopause. So what causes menopause? So the main cause of menopause is aging, the primary or leading cause. So it's the end of a woman's potential childbearing years. And what this picture shows is that your ovary gradually changes. And what happens is you can have complete or near complete resolution of ovarian follicular changes. So you stop releasing eggs. And as you go through perimenopause, by the time you get to a postmenopausal stage, then the follicles have become very, very small, and your ovaries are actually not doing a whole lot. So there are lots of changes, but this is what happens inside your body. So going back to that picture that we looked at before, the menstrual changes that happen in that perimenopausal frame, one thing is that the mid-cycle, or that follicular phase, starts to shorten. So instead of being around 14 days, it can drop down to around 10 days. The other thing that changes is that the length of the cycle can start to increase. So instead of being around 25 to 35 days, you can start to have it go up to 40 days, 50 days, a very much longer time frame in between your periods. And it's interesting to think about what happens next. It's just hard to predict when you're going to actually stop your periods altogether. There are some studies out there that say that once you end up missing a period for 3 months' time, then it could be 4 years before that final last menstrual period. So when does menopause actually start? There's no good proven way to predict a menopausal age, and because we make that diagnosis retrospectively, when a woman misses those 12 menstrual cycles all straight in a row, when she gets that diagnosis of menopause, it's a little bit hard to say when it's going to happen. Some things that we know are that menopause can start earlier or it can start later. Some women can have menopause as young as age 40 or less than age 40, and that's actually considered fairly abnormal. And a lot of times we'll start looking for other causes of what we call premature ovarian failure. Most women will go through menopause in their 50s, but some women might actually wait until age 60 or even age 65, and those are certainly outliers. Now, why would it be important to predict this final menstrual period? So this is a chart that comes out of a large group of women who have been studied from 1997 to about 2013. It's over 16,000 women, a big group, multi-ethnic study. And what they were trying to do was figure out what are the different stages of aging for women. And what became important is if we could predict the final menstrual period, it would have a lot of importance for preventative medicine. So what they were trying to figure out is what is that transitional phase, that perimenopausal phase, not simply so that women could figure out when it's going to happen, but we now know that there's a window of opportunity in that phase when you can actually start to improve your bone health, improve cardiovascular risk factors, improve lipid profiles, and perhaps even improve your health moving forwards into that postmenopausal stage. So menopause has a lot of different symptoms and complications, and we'll just quickly go through a few of these. Hot flashes are one of the most common symptoms, and you can have these at any time during menopause. About 80% of women actually have hot flashes, and we used to think that some cultures don't have hot flashes because Japanese women reported very few hot flashes, but what we now know is all cultures, women have about 80% of women have hot flashes, but the way women report hot flashes is very different. Only 20 to 30% of women actually report hot flashes. Less than 20% actually seek medical care or even medical advice for them. And that seems to be the same across all the cultures. So how did we find out this evidence? So Pauline Mackey is a PhD. She's a doctor out of the University of Illinois in Chicago, and she has done a lot of studies looking at hot flashes, or what we call vasomotor symptoms. And what she uses is this biolog skin conductance monitor. What it is it's a little monitor, and it has pads that go on your back and on your chest, and it measures the number of times you have a hot flash, the intensity of it, and then how frequent they are throughout the cycle of a day. So the reason why they switched over to using this was when people were using just a subjective recall and writing down on pieces of paper how many times they had hot flashes, it wasn't very accurate. So many women couldn't recall how many times they had them because they couldn't quite remember. And then the times that they were having them, sometimes they didn't even recognize them. So this became a much more accurate way to measure them. The picture at the bottom shows what a hot flash looks like. It has a tall spike and a little squiggly tail, and that's actually very different from sweating. Sweating looks like a very zigzag line, so then they could tell for sure that these were hot flashes. So a hot flash typically begins as a sudden onset of heat. It sort of rises in your chest, it goes into your back, it can go all the way up into your face, and then it can cause palpitations, anxiety, a very rapid heartbeat, a lot of different symptoms that go along with it. They last somewhere between 2 to 4 minutes, and it's very different how often women tend to get them. So from her studies, she showed that some women get maybe 2 a day, some people can have 2 every hour. So it's very, very different. One of the interesting studies that came up was looking at what are the patterns of hot flashes over time frames for lots of different women. And this was interesting because what it showed was there is no universal pattern. Women do not follow a pattern that works for every single one of them. And it changes during their time frame as they go through menopause. So people can have severe hot flashes well after menopause, and that line in red, those women are called the super flashes. So super flashes have frequent hot flashes all the way beyond age 65 into age 75. And that actually ended up being 42% of the population that they studied in that huge SWAN study that included 16,000 women. So it's actually a lot more frequent than we think. And it makes clinicians wonder when we start asking women to stop their hormone therapy because they're not supposed to have hot flashes after a certain time frame. We actually might be wrong about that. But interesting information. So cognition, or how your brain works, seems to be important. Sleep disturbance, depression, and dementia. Dr. Neil Epperson is a physician out of the University of Pennsylvania, and she's done a lot of work looking at the menopausal transition and how your brain works. So when we look at normal cognitive aging, or what your brain does as it gets older, you can divide it up into sort of 2 segments. Crystallized cognition is called the type of information that you have that is in your brain and it's going to stay in your brain. It's things that you learned over years and years of practice, so skills, ability, and knowledge. The fluid cognition is different because that is the day-to-day stuff that you do, the things that you rely on to be able to do things quickly. So processing speed, recall, mental flexibility, and then this thing called executive function. So the best way to describe executive function is, so here I am giving you this talk and everyone's trying to listen while I'm giving you the talk, but in the back of your mind, you might have thought of a really good question. Maybe it's about vasomotor symptoms. And then you think, I'm going to ask that question at the end of this talk. But chances are most of you are going to forget that question before I get to the end of my talk. And a lot of younger people, and younger women in particular, can keep that in mind and use some fluid cognition, bring that recall back 45 minutes or whatever afterwards, and be able to ask me that question. But most of us can't do that anymore. So then we get to the pieces of paper that we've given you guys, where you can write down that question and then recall it because you put it down in a paper format. So that is executive function. Your brain does different things. So executive function seems to happen in the prefrontal cortex, whereas that long-term memory or those concrete structures are happening in the hippocampus. So going back to that diagram that I showed you, there seems to be a window of opportunity in that perimenopausal time frame where estrogen seems to have a neuroprotective effect to help you with cognition as you get older. So this is a picture, it's a photon micrograph looking at neurons and how they age and showing these little things called dendritic spines, like little paddles at the ends of your neurons. So what happens is dendritic spines are very, very prone to getting damaged with stress, and stress can actually lop off those dendritic spines. But what they showed was if cyclic estrogen was used, those dendritic spines had more stability and they could actually last longer. The other interesting thing was depression in menopause, which is a very, very common symptom. About 3.5% of women go through a major depressive episode in that perimenopausal period. And a lot of times people will say, oh, it's because you've got mood changes, vasomotor symptoms, hot flashes, and it's just menopause. But it's actually not just menopause. It can be a major depressive issue. The timing of depression and stress seem to matter. Women who had adverse events happen in their childhood affected their hippocampus, which is that area that has the long-term memory, whereas teenagers, issues seem to affect the prefrontal cortex, which is where that executive functioning happens. If there's any good news, it was shown that doing a weekly cognitive activity, so whether it was reading, socializing, writing, socializing seemed to be very, very important. That was actually correlated with increasing your cortical gray matter and your hippocampus gray matter. So those things were shown to be very useful. And another thing that was shown to be a good thing was that when they did lifetime experience questionnaires on older women in their 60s and 70s, if they lost just about 3.6% of their hippocampal volume, they still had very, very high scores. So that was a good thing. When we look at dementia, unfortunately, there just is not a lot of information about dementia, and we really don't know how we can prevent dementia. There are 3 things that have been proven to be useful. So the first one, if you're a rat, you can actually prevent dementia by exercising. There's not a lot of good information in postmenopausal women and humans in general to show that it improves dementia, but certainly in rats it seems to. The Mediterranean diet, perhaps because of olive oil and grapeseed oil, there seems to be some good things about that, and Tai Chi. So those 3 things have been shown to improve dementia. Skin changes, so very important in menopause. The skin changes a huge amount, and these are micrographs showing what changes happen, and it's quite significant how that deficiency in estrogen thins down the epithelium, which is that top layer, but it also reduces blood supply, and there's such a lack of glycogen that you lose a lot of elasticity in your skin, and that's what leads to the wrinkling of the skin. So the important things about that, if you can start in the perimenopause by using a lot of things like SPF-based sunscreens, using petroleum jelly as a lubricant or a moisturizer rather than other things, anything that's a thick barrier type protection will really help in the postmenopausal period. Healthy diet and exercise helps. Sleep is a huge benefit, and then of course stress reduction. Soy is shown to improve skin as well. It's very rich in isoflavones, and it seems to act like estrogen in the body. Now, the caveat to that is you can't actually get the benefit by putting soy on your skin. You have to consume the soy, and then the soy gets metabolized, and then you see the benefits on your skin. And there's a little difficulty there because in the diet that we most of us have in North America, we have very few soy products. There's actually 3 things in our North American diet, frequent things. So that's soy, like tofu, edamame or soybeans, and then soy sauce. So compared to other diets, we have very little soy in it. The amount of soy that you need to eat, that's a little bit tricky because in an Asian diet, 6 to 18 milligrams of soy can be consumed every day. If you drink 2 8-ounce glasses of soy milk, you get 50 micrograms. So doubling all of that, it's almost inconceivable that we would get the right amount of soy. There are some other interesting things about how we metabolize soy as well, and I can go over that if someone has a question at the end. But soy is a very interesting topic. Cardiovascular disease. So this is a really important issue because there are things that we can use to try and prevent cardiovascular disease in the perimenopause. We know that there are changes that happen due to estrogen deficiency, and part of it is because our lipid profiles change during the perimenopause, and that could have an effect. But also the way that different measures that we have for our lipid profiles and our cardiovascular health can change as well. One thing is HDL. So HDL is high density lipoprotein, and that's something where if you exercise a lot, your high density lipoprotein levels go up, and that's supposed to be cardioprotective. Interestingly, in the postmenopausal period, HDL might stop being cardioprotective once you go beyond that window of opportunity, which is something we didn't know because a lot of those studies were initially done in men. So Dr. Hodis is a physician who's working on a study called ELITE that is looking at how to improve cardiovascular health in women, and he's one of the primary investigators. And what he showed was that the sequence of aging in your coronary arteries can be quite different depending on whether hormone therapy is used or not. The first picture shows the changes that happen in a coronary artery. So as you get older, you can have fat deposits, or what we call atherosclerosis, start to sit inside those vessels. And then later on, they form a plaque. And as that plaque gets older, the plaque can become unstable. And that's when it can rupture and then lead to a heart attack or a stroke or something like that. In women who started hormone therapy early for vasomotor symptoms, hot flashes, things like that, starting the hormone therapy early seemed to stabilize changes in the arteries, and you didn't actually get to the point of a plaque where you could have a plaque rupture. Now, if you started hormone therapy later, say after age 65, then that wasn't good at all, because what tended to happen was you developed a thing called a mural thrombus sitting right on top of everything, and that was very likely to rupture and go up and cause a heart attack. So these changes were very interesting. The other thing he found was that women and men have heart disease in very different ways. Men can have changes in their large vessels, but women tend to have more microvascular changes, which changes the way that women present with symptoms and also the types of diagnoses that we can use for them. So when you look at a vessel, men tend to have changes in those large vessel coronary arteries, but the microvascular system, those tiny little vessels that are working on all parts of the heart, that seems to be where women show it. Now, the big difference is women then have more heart failure than men. Not MIs or heart attacks, but more heart failure, which is actually a different condition. So 70% of women with heart failure are actually older than age 50, and it's actually now one of the major causes of death in older women. And the 5-year and 10-year prognosis is actually very, very poor for women with heart failure. So what he concluded was that menopause can play a clear role in coronary microvascular disease, and they're looking for sex-specific opportunities to try and improve these symptoms. And perhaps there will be a role for estrogen therapy or continuing some form of estrogen therapy to improve this, but it certainly changes the way we look at heart disease in women. So breast changes. One of the biggest changes in the breast is that the density of the breast changes with age. A good thing about it is that mammograms become more and more acute and can find breast changes or breast cancers more accurately because of those changes. And the other thing that happens is that breast cancers or tumors tend to double at slower time frames as you get to postmenopause. So it can take longer. Rather than 50 days or 150 days in the postmenopausal period, tumor doubling occurs in about 200 days. So it does help with mammograms in detecting these. There's a lot more on breast changes and estrogen levels, but I'm not going to go into that today. Vaginal dryness, very, very common symptom, and it can be extremely bothersome. And the changes in vaginal dryness are mainly seen similar to the changes we see in the skin because of the changes in the superficial cells and intermediate cells and how that epithelial lining changes during the menopause. So sometimes women will notice a slight decrease in vaginal lubrication or a decrease in sexual arousal, and that's one of the first signs that you could have some estrogen insufficiency. And then as this state becomes more chronic, people can notice the vaginal dryness symptoms even when they're not having sex. It might be just when they're sitting down or walking, and those symptoms can become worse. So the same thing, you can see how remarkable the change is in the vagina, where the epithelium becomes so very, very thin and doesn't have any of that protective barrier anymore. This picture, I hope you can all see it, is a really good demonstration of what actually happens in the vagina. So if there's any place that you want to have wrinkles, it's in the vagina. And you want to keep those wrinkles in the vagina as long as you can, because that's what helps you as far as natural lubrication, sexual arousal, a lot of different things. But in that transition phase, and certainly in the postmenopause, loss of those wrinkles can be a major factor as far as how women are going to have sexual intercourse. And that's something that we often see clinically. And a lot of times, if you can look even with the mirror, you'll probably see some changes. Bone loss. So bone loss is a very important factor in that perimenopausal period. And this is one of those areas where we really try and have as much as we can for prevention. This photomicrograph is a really good demonstration of what happens to bone as you go from normal bone towards osteoporosis. And what's really striking is that the bone doesn't just thin, it actually increases all of those big pores, and you can see how unstable that's going to be once you get towards osteoporosis. The changes are not just that the strength decreases, but there's no more elasticity, and fractures are far more common. Menopause and bone loss. Women tend to lose bone rapidly in that first year right before they get to menopause, and then in those 2 years, in the beginning of menopause, there's a really large, rapid decrease in bone loss. What's interesting about this curve is everyone seems to have the same curve. So whether you start with a really high bone mineral density or low bone mineral density, the curve is the same for everyone. So if you start off high, you might not end up as low as the other person, but that curve is still going to happen. So you're still going to lose bone rapidly in the beginning and then hopefully plateau out as you grow older. Another opportunity for that timing hypothesis, when they did studies looking at estrogen use during this time of rapid bone loss, what they showed was that current estrogen use reduced fracture risk. And if women had early, so in that perimenopausal time frame, early continuous use, then that had the greatest improvement in fracture risk. And then once they discontinued it, you went all the way back to the same bone loss as a person who was not on estrogen. So those two conclusions, one is that current estrogen use can reduce fractures, and that early continuous estrogen therapy has the greatest effect on improving bone health. So genitourinary syndrome of menopause. So this is a term that's come up, and it's going to be more and more frequent over the next few years. What it describes is everything that happens in the vagina and the urethra and the places where your bladder is. So things like urinary frequency, painful urination, having some form of incontinence or leaking of urine, but a lot of those symptoms that women seem to have, and also frequent urinary tract infections. Now, with that, what's been shown is estrogen is vaginal estrogen. So local topical vaginal estrogen is very, very effective for this condition. And it can work extremely well, and it has a very low risk profile. So this is one of the executive directors of the North American Menopause Society, and she was tasked with coming up with the new NAMS hormone therapy position statement, and this is available on the website. It's open to the public. And one of the conclusions was that hormone therapy is the most effective treatment for vasomotor symptoms and for genitourinary syndrome of menopause, and it's been shown to prevent bone loss and fracture, and that is what we call level 1 evidence, or very good evidence. I'm going to end up by showing you this app. Everyone loves an app. It's a mobile app and it's free, so anyone can look it up. It's called Menopro. And what it does is it can be used as a clinical decision tool where you can put in information about yourself and then see if you're going to be a candidate for hormone therapy and whether it's going to actually benefit you as far as your cardiovascular health and your bone health. Those are the primary things that are on this. The nice thing about it is, and I hope you can see it, it has a provider section, so healthcare provider section on the right-hand side, or left-hand side for you, and then a woman or patient section. So you can go into the app and put yourself in as either one of those. And you go through a few little stages, and I think I put me in as a provider when I did it, but you put in your blood pressure, what your cholesterol was, some information about past medical history, family history. And it spits out this report that talks about what your cardiovascular risk score is over the next 10 years. And what it says is whether you can use estrogens or progesterones, or if another form is better for you, and then what those forms would be. And then I put the second part of it in. There we go. So right in here, it says you can email it. So you can actually email the report to your provider, or your provider can email the report to you, and then you can have a conversation about whether you're a candidate for hormone therapy or non-hormonal therapy, or methods in which you can improve some of the symptoms of menopause. So the biggest thing about perimenopause and menopause is that it's such a difference between different women that it is very much individualized treatment. And when we come up with methods of treating the different symptoms, it has to be a shared decision making that goes on, because that's really the only way that we can benefit our patients. So thank you very much.
Okay, the subject of menopause. And I ponder about the word. Why is it pause? That mystifies me as I started to think about it, because it really is a transition, but it's when your cycles stop, as we just learned from Dr. Cotter. This is my hometown of Shrewsbury. Jessica, the Hereford cow, and Bullwinkle the moose were 30 years ago right now. And I've lived in this community for the past almost 30 years and had the privileges of delivering many babies and the babies of their babies. And the mom of the first baby I delivered is in this room. And during this time frame, I've raised a family, and I've gone through many of the life cycle reproductive changes that my patients have. And 6 years ago, I'm done with menopause, and it was a wonderful thing. I don't miss periods at all. So the definition, as we know, is when your ovaries cease estrogen production and your periods naturally cease. At birth, we're born with 1 to 2 million eggs or follicles. During the course of our reproductive years, we lose approximately 500 of those eggs to ovulation. And as we age, the quality of our follicles and the quantity of our follicles diminish. And by menopause, only a few thousand follicles remain. Now, in the year 1900, a woman's life expectancy in this country was 42. And now your life expectancy is 78 and climbing due to the miracles of modern medicine. The symptoms of menopause include the vasomotor symptoms of hot flashes and night sweats. And again, the hot flashes manifest by a sudden feeling of warmth in your upper body and face. It may last a few seconds to 1 to even 5 minutes. The physiologic mechanism for hot flashes is not clear, but there appears to be a central signal, probably from the hypothalamus in the brain, that causes an increase in your core body temperatures just ever so slightly, accompanied by increasing metabolic rate and in your skin temperature, causing vasodilation, your little blood vessels dilate, and then you start to have this sweat. Hot flashes, again, can be characterized by sweating, a sensation of anxiety. Could you just have the sudden warmth where you just makes you anxious, and on occasion, heart palpitations. Approximately 87% of women will experience hot flashes on a daily basis, and 33% of women may have more than 10 a day. Symptoms may last anywhere from various reports 6 months to 2 years, but some reports are 4 to 10 years. And as we learned from Dr. Cotter, there are certain women who are super flashers. Lifestyle factors can be associated with exacerbation of hot flashes and their severity, and some of these include a caffeine intake, alcohol intake, stress, and a warm temperature, the environment in which you're in. Temperature can affect that. Vaginal dryness, as we know, is the thinning, drier changes due to estrogen lack, deprivation, and that the vaginal tissues become less elastic and therefore more discomfort with sexual activity. Other symptoms and things with menopause are sleep disorder and a disordered mood, 2 to 4 times increase in the risk of depression after menopause compared to premenopausal women. But this depression can also be associated with social stressors that are going on. I mean, I think as we age, for many of us, life gets increasingly more complicated. We're raising children, issues with children and family. We have aging parents. We've done the role reversal where we have been taken care of by our parents, and now we are taking care of our parents. And also social stressors, loss of a partner, financial and work challenges, family and personal challenges, all can add into that. Cognitive function, some postmenopausal women performs worse on certain verbal fluency and memory tasks than perimenopausal women. And these cognitive symptoms are influenced, again, by midlife stressors, but also include disturbed sleep and fatigue as a result. Bone changes, as we know, a small amount of bone loss after age 35 is normal for both men and women, but during the first 4 to 8 years after menopause, women lose bone more rapidly, and this is because of the decreased levels of estrogen. And if too much bone is lost, you're going to be increased risk for osteoporosis. Approximately 10 million people in the U.S. have osteoporosis, and 80% of those are women. Increases the risk of bone fracture, and the bones of the hip, wrist, and spine are affected most often. What other health risks increase? Estrogen produced by your ovaries protects against heart attack and stroke, but when less estrogen is made after menopause, women lose some of that protection. And midlife is also the time when risk factors for heart disease, such as elevated cholesterol levels, high blood pressure, and being physically active are more common. And all of these combined factors can increase your risk of heart attack and stroke after menopause. Cardiovascular disease accounts for 45% of women's mortality, especially in women who have diabetes, hypertension, elevated lipids, hyperlipidemia, and the risk of heart disease increases after menopause, especially after age 65. Management of menopausal symptoms that do not involve taking a medication. A cooler environment. Turn down the thermostat rather, and have a fan going. A fan by your bedside table. Open up the window. A fan at your desk, on top of your desk, underneath your desk, and you can get some pretty quiet fans that are not obtrusive to your working environment. Clothing, dress in layers, breathable fabrics, so when you start to get a hot flash or feeling warm, you can take something off. Adipose tissue is insulating. Think of people in the Arctic and how they dress. Think of animals in the Arctic and swimming in that incredibly frigid water and laying on the ice floes, they are insulated. So heat can't get out. Cold is less apt to get in, but heat can't get out. So weight loss, if you're overweight, can truly help with the severity of your vasomotor symptoms such as hot flashes and sweats. Dietary changes, as we heard from Dr. Cotter, increased soy in your diet can help. Soy is a form of phytoestrogen. There's chocolate soy milk and vanilla soy milk. Someone told me Price Chopper had a vanilla ice cream bar with chocolate. Edamame, soy nuts as a snack food. They're pretty tasty, crunchy little soy nuts in your salads, a half a cup of soy nuts a day. Chickpeas, lentils, and yams are other foodstuffs rich in phytoestrogen. Not sweet potatoes, but yams. Paced respirations. This was an interesting concept. Your normal respiratory rate is approximately 12 breaths a minute. They say to practice 5 minutes in the morning, 5 minutes in the evening. And what you do is you inhale very slowly for 5 to 7 seconds, and then you exhale slowly for another 5 seconds. And if you can master this technique with the onset of a hot flash, and you start to do this slower breathing, inhalation and exhalation, it can resolve the hot flash faster. So it's worth a try. Exercise, yoga, can help improve your sleep quality and your mood. And exercise is always a very worthwhile thing for both this purpose as well as your cardiac health and your longevity. Going back to dietary changes, in addition to the phytoestrogens, black cohosh, some of the herbal remedies, vitamin E, evening primrose oil, there's a variety of herbal supplements. The thing you have to be careful about is the over-the-counter supplements that you buy may not be what they purport to be. And to go to the actual, soy, chickpeas, lentils, yams, or go to an herbalist and really know that you're getting the right thing. Other lifestyle changes are smoking cessation. Smokers tend to go through an earlier menopause by approximately 2 years, but smokers also have worse vasomotor symptoms. Their hot flashes and night sweats tend to be more severe. So smoking cessation will help. Reducing your caffeine and your alcohol intake is also useful. Hormone therapy involves either estrogen or a combination of estrogen and progesterone, or local estrogen therapy for use in the vagina. Estrogen is really only indicated for women who do not have a uterus. I heard a speaker many years ago from British Columbia who had a great analogy of how to think of estrogen and how to think of progesterone. Estrogen is the fertilizer. It makes the uterine lining grow and thicken, whereas progesterone keeps the uterine lining thin. Unopposed estrogen in a postmenopausal woman where you're giving her unopposed estrogen treatment, you can get an excessive thickening of the uterine lining that over time, some abnormal cells can arise that can progress into a uterine cancer. So a woman with a uterus in place needs to have both estrogen and progesterone to prevent that from happening. So the FDA approves of systemic estrogen treatment for the relief of vasomotor symptoms. And again, if no uterus, estrogen alone, but if a uterus is present, you need to have both estrogen and progesterone to prevent excessive endometrial thickening, what's known as endometrial hyperplasia, and to prevent endometrial cancer. Estrogen, progesterone hormonal treatment can be oral delivery, it can be transdermal, it can be a topical gel or spray. The local estrogen therapy in the vagina, there can be a tablet or a ring for local relief in the vagina that really minimally raise the estrogen level, if at all, so there's really no effect on breast or uterus for the local estrogen treatment. However, there is a ring product called Femring used for hormonal replacement, and if that is used, you do need to take oral progesterone in addition. A woman's risk of breast cancer can increase with the duration of hormonal therapy use, and after 5 years of use with a combined estrogen and progesterone treatment, the risk can rise. But after risk of breast cancer in a woman on estrogen treatment alone, there's really no significant risk of breast cancer, very minimal if at all. Compounded bioidentical hormones are not FDA approved. They're not required to have warning labels. The quality control and creation of these compounds can be an issue. Doses can vary from batch to batch. There can be inactive ingredients that can vary within the compound, and the freedom from contamination is not guaranteed. And these products are oftentimes not covered by insurance plans. But I certainly have patients who use these products, they obtain them locally, and I think you have to trust the pharmacist who's creating them, that they're doing the proper job. Benefits of hormone therapy. As we've heard, the systemic estrogen therapy, with or without progesterone, has been shown to be the best treatment for the relief of hot flashes and night sweats. Both systemic or local types of estrogen therapy can relieve vaginal dryness. Systemic estrogen protects against bone loss that occurs early in menopause and can help prevent hip and spine fractures. Combined estrogen and progesterone may also reduce the risk of colon cancer. The risk of hormonal therapy, estrogen-only therapy, as I just alluded to, can increase the lining of the uterus to grow and increase the risk of uterine cancer. Combined hormonal therapy is associated with a small increased risk of heart attack, but this may be related to age, an existing medical condition, and when a woman starts taking her hormonal therapy, as we learned from Dr. Cotter's talk this evening. Combined hormonal therapy and estrogen-alone therapy can be associated with a small increased risk of stroke and deep vein thrombosis. Deep vein thrombosis is when you form a clot in not a superficial vein, but a deep vein in the leg or the pelvis that can flick off and go to the lung and cause a pulmonary embolus. Forms of therapy not taken by mouth, such as the estrogen or estrogen-progesterone patches, sprays, the vaginal rings, have less of a risk of causing deep vein thrombosis than those that are taken orally. Combined hormonal therapy is also associated with a small increased risk of breast cancer after 5 years of use, and that's for the combined estrogen and progesterone formulation. There's a small increased risk of gallbladder disease associated with estrogen therapy, with or without progestin, and the risk is greatest with the oral forms of therapy. Non-hormonal therapy. What are our alternatives? Antidepressants have been available for the treatment of hot flashes. They're not FDA approved. It's an off-label use. Some of these medications include Effexor, Celexa, and Lexapro. Clonidine is a blood pressure medication that can help with vasomotor symptoms. Gabapentin or Neurontin is an anti-seizure medication that can also be efficacious. They are prescription drugs that can be prescribed to reduce hot flashes and help sleep problems associated with menopause. And there are selective estrogen receptor modulator drugs as well that act on tissues that respond to estrogen. Plant and herbal supplements, as I've already alluded to, the phytoestrogens, the black cohosh, and so forth, can help alleviate some symptoms, and they're perhaps effective in 30% of patients. When they've studied these medications, though, they haven't been proven to be superior to placebo. There is one FDA-approved medication that's non-hormonal for the treatment of vasomotor symptoms, and that's called Brisdel or paroxetine. It's a 7.5 milligram tablet that you take at bedtime that can help reduce vasomotor symptoms. And that is the same antidepressant as Paxil, and that is a non-hormonal FDA-approved medication for menopause. Sleep medications can help reduce sleep disruption. Over-the-counter Benadryl is a product that may help, and then there are also some prescribed medications as well. Other tactics are acupuncture, the herbal products, vitamin E that I've spoken about, but again, they're not superior to placebo when they've been studied. I got ahead of myself. Sorry about that. The most important thing is when you go through menopause, it's a normal phenomena. It's supposed to happen. It's a good thing, getting rid of your periods, in my opinion. And you have to meet it head on. I once heard a woman speak who was a board-certified OBGYN as well as a psychiatrist, and she had a study she alluded to with behavioral aspects of menopause and how a positive attitude made a big difference in how patients cruise through that phase of their life. So maintaining good health is extremely important. Back in your reproductive years, any woman who had a history of gestational diabetes, that was a red flag to you back then. To watch your weight, maintain good health, because that's a risk factor later on in life for overt diabetes and the accompanying problems such as heart disease and so forth. Women who have a history of preeclampsia during their pregnancies may have an increased risk of heart disease later in life. So this is the time to be very proactive with your health and take charge. Exercise is very, very important. Exercise is good for your cardiac health. It's good for your bones. Weight-bearing exercise, working out with the weights, an elastic band, hand weights, helps maintain the mineralization in your bones. A healthy diet, avoiding a lot excess fat and processed foods. A good idea is shop the periphery of the grocery store. Everything is fresh, everything made from scratch. Stay away from the processed foods with the salt, the sugar, the preservatives, and what else is not good for you. Adequate calcium and vitamin D in your diet is important, at least 1,000 to 1,200 milligrams a day. Dairy is a good source because of the calcium and the vitamin D that's in it. Vitamin D helps you absorb the calcium more readily. And the thing about calcium intake is you want it in divided doses throughout the day. If you ingest it all at once, you may only absorb a fraction of the calcium. A glass of milk has about 300 milligrams of calcium, and it has vitamin D. An ounce of cheese has 200 milligrams. Hard cheeses such as cheddar may have more calcium than the soft cheeses. Broccoli, cauliflower, kale, your kale-type vegetables have 200 milligrams a serving. Yogurt is 400 milligrams a serving, and it's got the vitamin D. The calcium-fortified orange juice and grapefruit juice has vitamin D added, and it's actually a bit more content than milk. It's about 340 milligrams a glass. You need to be proactive with your health care maintenance. Be diligent about your yearly mammography, your colorectal screening, your lipid screening, and your diabetes screening. So the grass can be greener on the other side of the fence, but you've got to make it happen. You've got to take charge of your health and work diligently with your providers and achieve your health goals. And I think Rutland Regional here has many resources for you. There's numerous healthcare forums and activities that we invite the public to participate in, all in the interest of your good health for many, many years. This is another view in Shrewsbury. All right. Thank you, and now we'll entertain your questions. Does anyone have any questions you want us to pick up? Yes.
With the change in the hormone replacement therapy, it sounds like it's safer now. But if you have a history of breast cancer in your family, should you still consider using that type of therapy?
It depends.
Higher risk still?
Well, it depends on the number of family members. Who were they? First-degree family members? Was it a mother, sister? Were any of the family members premenopausal? Did anyone have any genetic testing to see if they were a mutation carrier, the BRCA gene?
Right, yeah. It was after menopause. It was my mom.
Mm-hmm.
Didn't do the genetic testing.
Okay. Is she still living?
She is.
Okay. Do you know if her particular tumor, you can find out if her particular tumor was the type that would be possibly, a mutation carrier?
I can check on that.
Yeah. Because I think according to the histology and the markers, the cell markers, they can get an idea of that. I think to be diligent with your monthly self-exam and your routine mammography is very important for anyone around, using hormonal replacement. And the goal with hormonal replacement is to use the lowest dose to alleviate your symptoms and for the shortest time. Women should be less than 60 years of age and no more than 10 years from their onset of their very last period. You don't want to use it for a prolonged amount of time. Yes?
Are there soy supplements available other than if you're not able to get that soy through dietary?
There are. I think CVS has their own concoction called New Phase. There's Remifemin, Rejuvex. There's a number of formulations out there. But again, they say that some of the over-the-counter things that you buy may not be what they're supposed to be.
And just to add to that, so the soy question is actually very interesting because a lot of the studies on soy are actually done in kids because kids end up having soy formula.
Mm-hmm.
And there's a lot of work that's done actually through Cincinnati Children's Hospital looking at soy and how we actually can metabolize it. So when you consume the soy, it has to be changed into isoflavones in your body, and from then it has to become a product called diamine. And then that diamine product actually goes through another enzyme change, and then that becomes estrol. Only 35% of the North American female population has the enzyme that can convert diamine into estrol. So interestingly, a lot of women who consume soy might not have that enzyme, so they actually may not have the benefit of being able to convert the soy products they eat into estrol. And that's the same for the soy that's in supplements. The other interesting thing is supplements. It's very cheap to make a supplement that has something called an S isomer of, this is getting very chemical, but if you remember organic chemistry, there are always, but there are always two versions. So there are isomers of different molecules. There's a racemic molecule, which is called the R, and then an S molecule, which is like a mirror image of that molecule. It is much cheaper to make the version that is not the one that can be converted into the estrol in women. So a lot of supplements have the wrong racema to then make estrol in the body. So that's where... So exactly.
Right.
And unfortunately, you have to eat a lot. You have to eat a lot of tofu to get the benefits of it. But it's very interesting. The other one thing I found that was interesting is when they did the studies on the kids, they found that babies, they wanted to show that breastfeeding is going to be great for kids, etc. But in the kids who had the soy-based formula, they maintained all those estrogen-type benefits long into their older years. And they actually saw improvements in different cognitive things in those body babies. It's just interesting how much we probably don't know about soy and some of the recommendations we make from it.
Thank you.
Yes?
I have two questions, I guess you can both comment. One is on the bone loss issue. Is there still solid research that exercise and all of that is a really positive intervention in terms of prevention, or is the hormone therapy a much bigger piece in that window that you're talking about, that sort of early menopause window?
Well, T, I'll let you answer this, because that sort of goes to that graph that you had,
Yeah.
where you saw a protective effect and then it
Right.
really fell off when you
But I'm just wondering,
ceased
if one
treatment.
doesn't want to do the hormone therapy, are the things like exercise and those really beneficial to the bone loss piece?
So the exercise is always going to be very, very beneficial because yes, it helps with the bone loss, but the other area that people are now saying that we should look at is, so we look at something called osteopenia, which means starting to lose your bone mass. We haven't looked at this condition called sarcopenia, which is the muscles that are going around your bones. So we always focus on the bones, but what they showed was that women who had osteopenia and osteoporosis were still having falls, but it wasn't related to their osteopenia or their osteoporosis. So why were they falling? And what they found was it's that muscle mass around the bone. If you don't exercise, and you can go on estrogen and improve your bones, but if that muscle mass or the sarcopenia is there, where you don't have the muscle mass to help you balance and prevent falls, then you're not going to see those same benefits. So yes, definitely, the exercise is always going to be important just for balance and improving your bone function. And estrogen probably will have better effects compared to other things that we have.
I've seen patients, really go into a dedicated exercise regime and being very diligent with their calcium and vitamin D and so forth, and repeating a bone mineral density at a later time and actually seeing an improvement when they take that
Would
on.
you recommend starting to have like a baseline done on the bone density medically?
Well, I think, after menopause, if you're not on estrogen treatment, if you've got a strong family history of osteoporosis, if you're very, very lean, if you're a smoker, if you've ever taken chronic steroids during your lifetime for, like asthma or rheumatoid arthritis or whatnot, thyroid disorders, those are folks that may be at increased risk. Otherwise, I think it's after age 65.
And that might change over the next few years as well, because a lot of our societies and bodies of evidence say to start at age 65.
Right.
But what's interesting is at age 65, we've missed that window of opportunity,
Right.
and we're looking then at treating osteoporosis. We've missed the chance to treat osteopenia and sort of prevent the bone loss. A lot of European countries now are looking at that prevention part more and starting bone mineral density testing around age 55. So you can actually work on that before you start dropping on that scale.
Right.
So we
And that's
might
what
start
I was
to
wondering
see-
about, was that issue of that window and then missing that, and when do you start really looking at that?
Yeah. So that might change, over the
Yeah.
next few years or so. That might actually not
Yeah.
end up being age 65.
And the best method is a DEXA scan, where you're measuring the density of the spine and the hip, because that's your major supporting axial skeleton. To do your finger or your wrist or your heel doesn't tell you what's going on with your hip and your spine, and that's important.
And I think that's a really good point, because I actually didn't know about the foot bone density measurements. And in women in particular, it's not useful at all, because that's not where you have osteopenia. You have it in the locations that Dr. Beerworth talked about, in your hip, your spine, your vertebral body. So if you have a normal test on your foot, it doesn't tell us anything about what your bone health is.
So the bone density, it's not systemic, that loss of bone density happens more in certain areas of your
Well, I think it's
skeleton?
looking at the areas of importance. Hip fractures, vertebral fractures, wrist fractures are the most common fractures with women when they suffer a fall.
Because that's where you fall, but is your bone loss in every bone, or is the bone loss more concrete in the spine and the hip bone?
So that's actually a really important question, and that's something that they're looking at. And part of it is because a lot of the studies that gave us our little algorithms that we use to figure out who is at risk for osteoporosis were based on lots of different areas of the bone that might not have targeted the places like the wrist, the spine, and the vertebral bodies that are more important for women. So they're looking now to see if perhaps we can get a better evaluation for women that might be a little bit different than the bone mineral densities that we have for men. But yes, you're absolutely right.
Because
there are some places that
the
are
recommendation
different.
is weight-bearing exercise. So what is that? Walking.
Walking is one,
But
but
what does
you know.
it mean if I walk a lot, my neck will have a great degree of osteoporosis if that's what's happening?
No,
No.
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 And weight-bearing exercise, working against resistance is what's
That's
important.
what I mean. So
You know,
also
your
have
muscles,
to
your
have-
tendons, tugging on your bones, and that's what stimulates the bone to maintain the mineral
So
density.
not so much walking, but also weight.
Everything. A lot of communities in the area have a bone builders groups, and very worthwhile. Participate. Yes.
Are there things that you can do while in perimenopause to be prophylactic for yourself during menopause?
I think you know the healthy lifestyle is very, very important. You want to address that too?
Yeah, I mean, definitely all of the healthy lifestyle type things are important. And then certainly, like our recommendations are if you have symptoms, so hot flashes primarily, and then the vaginal dryness or those genitourinary syndrome type symptoms, then it might be worthwhile to tell your provider so you could try something that's an estrogen-based product that would help with those symptoms. And then long term, there's likely going to be some benefit of it. And it's hard to sway people in one direction or the other because all of this changes and it might be different. I mean, sometimes you come away from a talk about peri-menopause and menopause and you say, boy, you know, I wish I just stayed on that birth control pill until I got to age 55 because it looks like that was the best thing I ever chose because the benefits certainly outweighed the risks. But it's always, everyone's individual, so some women might not be good candidates for things like that.
You had also mentioned that in that phase that you lose blood supply, which might affect your circulation in your extremities. And I have Raynaud's syndrome, so will that be increasing over time?
It's difficult to say only because a lot of the studies are looking at the macrovascular changes, like that picture that I showed you. And Raynaud's as well is a microvascular change. And we can theorize that it can have effects where estrogen can improve those changes, but it's just hard to say what's going to happen. In women who have those sorts of immune-mediated things like Raynaud's, we always say it's like a third might get better. In that postmenopausal transition, a third might stay exactly the same, or a third might worsen. But there's not going to be a hard and fast rule. And certainly it hasn't been shown that staying on estrogen or estrogen therapy for Raynaud's might help. It's a very good question.
Interesting question.
Yeah.
Yes.
I have another question for you, Dr. Cotter. I was interested, I'm actually a clinical social worker, in the brief little piece that you did with major depressive disorders during perimenopause, and the slide that you had about the hippocampus and the prefrontal and kind of the early childhood versus teenage stress. Could you just comment a little bit more on that? That was very interesting to me professionally.
So what they talked about was that when they looked at early childhood stresses, there were certain parts of the brain that were very definitely affected.
Right.
And what was interesting was like that age group 3 to 5 years old, and it certainly is like probably things that you hear about, very distinct adverse effects and adverse events. That hippocampal region is the area that works on long-term memory. So it almost makes a protective or evolutionary sense to say that if something terrible happened in childhood, you probably would want to forget it. So your long-term memory might be the area that has an effect, and then it unfortunately carries out through adulthood. And then the interesting thing for the postmenopause talk is that teenagers, so those teenage girls, you would hopefully try not to have them have a lot of adverse events so that it wouldn't affect their prefrontal cortex.
Right.
And then the executive function type things that we all struggle with might have a longer time frame.
And what was the specific relationship between the increased likelihood of a major depressive disorder during perimenopause and those two elements? Was it that if you had these stressors that you were more prone to then have this major depressive disorder during perimenopause?
Yes,
Okay.
exactly.
I thought
Yeah.
that was the link, but I wanted to make sure I had it organized. Thank
Yeah.
you.
Yeah.
Just talk a little bit about the compounding. I know you weren't that keen on it, but can you just...
Well,
I'm
it's,
actually glad you
it's
mentioned that.
compounded bioidentical hormones, and that they're plant-based, and they're not approved by the FDA. I'm leery of patients who order away, mail away for these products, because I just don't know what they're getting. But to work with a pharmacist locally who you trust, who you know who does a good job, and you specifically speak with that person about the exact proportions you want, making them very comparable to a prescribed pharmaceutical product. But again, they're not FDA approved and it's not guaranteed. And most insurance plans won't cover them.
And I think there are rules for compounded medications. So, someone could be allergic to red dye in a medication. So then a compounded pharmacy might make the same thing without the red dye, and then the patient can take it. But really, the compounded estradiols and progesterones and things like that, they all come from a factory in New Jersey. It's got all the plants in there, and really that's where it's coming from. So estriol and estradiol comes from New Jersey. Whether you order it from away or do a mail order, it's coming from there. And the difficulty, as Dr. Beerworth was saying, is we don't have any idea about how much actually gets to a woman. And there were some really interesting studies where they showed a compounding pharmacy product where it was a topical estrogen, so one that people rubbed on the skin, and they used the exact same formulation in about 6 different women, and then they tested their blood levels at different times. And in some women, the estradiol level, when they tested it, was about 10 micrograms, and in the next woman, it was 250. In the next woman, it was about 600. Exact same product, but completely different blood levels in the serum. So that's where the FDA comes in and the physicians come in, and then we get nervous because we can't tell how much you're actually getting. There's no way to actually know what that dose is.
So what do you do with a woman that is in menopause surgically but cannot be on any kind of NAP or any kind of hormone due to PD?
Due to history of pulmonary embolus. Some women get by with progesterone only form of replacement, which has a less of a risk profile.
And then the non-hormonal.
And then the non-hormonal,
Yeah.
the Brisdel, the 7.5 milligrams of paroxetine at bedtime can help.
Yeah, but that is a difficult one. And that's only because we'll probably see evidence that estrogen alone is going to be very, very beneficial for a whole lot of different things. But the thing that we won't be able to walk away from is that estrogen, and even estrogen and progesterone, although it does increase the risk very, very slightly of pulmonary embolus, venous thrombotic event, and stroke, even that slight increase, it's a big deal. And it's just not worth the risk benefit then.